Sorry, I didn't. Sorry, Dr. Chitok, I didn't prepare a pediatric patient, but
That's fine.
for the past 2 weeks, for the past 3 weeks, we've had 2 cases of splenic abscesses. So I thought to read around it and present it to the class. So this is our presentation for today: splenic abscesses and open splenectomy. So just briefly going through our anatomy. So there's an imperial rule that you can use to remember the anatomy of the spleen, and they usually call it the 1, 3, 5, 7, 9, 11 rule. And they usually say the dimensions about 1 by 3 by 5 inches long. And this is average, and the weight is about 7 ounces, and the it lies at 9th to the 11th rib. So that's where you get those derivatives of your odd numbers from. In talking about the spleen and the splenectomy, it's important to learn about the ligaments and their attachments. So as you can see, there are two vascular ligaments that carry blood vessels with it, and 2 avascular ligaments. So laterally, we talk about the linorenal or the linoleal attachments. So this come from the kidneys on top, and they cover the spleen laterally. Anteriorly down here, you have the gastrosplenic ligament that comes from the greater curvature of the stomach and usually carries your 2 vessels, your short gastric and your left gastroepiploic vessels, both arteries and veins. And then you have a superior covering that attaches the spleen to the diaphragm, which is known as the splenophrenic ligament, and then inferiorly from the colon to the spleen. These are all important ligaments, especially when you do dissections in splenectomies. The relations is also important because not only do you use it anatomically when you dissect, but there are regions where you look out for as an etiology for splenic abscesses, and these are the regions that you look for in terms of complications post-dissection. So anteriorly, you have the fundus of the stomach that forms an impression on the spleen. You have medially, as you can see here, you have the tail of the pancreas. Below, you have the splenic flexure from the colon. So that's where you have your splenocolic ligament. And then superiorly, you have your diaphragm. So you have your phrenic attachments there. And then apart from that, you have your relations to the kidneys, which is also important. The surfaces, as I mentioned, you have your renal impressions, you have your impressions from the pancreas, the stomach, and also from the gastric portion of the greater curvature of the stomach. The arterial supply is also important. The main supply is by the splenic artery, which is off the celiac trunk. Then you have other divisions such as the short gastric arteries and also the left gastroepiploic. In 1924, this gentleman, Michael, had studied the distribution types of arterial supplies for spleen, and he found that there were 2 main arterial distributions. He found for spleens. He found that 70%, the majority of the patients had a distributed type, where you have a very short splenic artery with the divisions about 3 to 13 centimeters before the hilum of the kidney. And then this distribution covers about 75% of the medial surface of the spleen. And the uncommon type is the one you see here. You have a longer length of the splenic artery, and then near to the hilum, you have a shorter distributions, which covers 30% of the medial surface. But in general, the splenic artery divides into 2 lobar segments, anterior and posterior. And from these lobar regions, you have segmental arteries, and they form like wedge-like areas where they supply it. So in between the lobar segments and the segmental areas, these spleens are very avascular. So when you have a devascularized segment of the spleen, it's important to know the arterial distribution, because you can do a partial splenectomy through these avascular planes by knowing the type of blood supply that you have. The venous drainage, as we know, it covers from left to right in a spleen, and it's behind the body of the pancreas as opposed to the arterial supply, which is on top of the pancreas. And the main area, the splenic vein then joins the the superior mesenteric vein to form the common portal vein, but you have other tributaries around that region that contributes to the venous drainage along the splenic vein. This is something that is very important to know of, especially when you do a splenectomy in patients who have an underlying hematological cause of doing a splenectomy, because these are the areas that you look out for an accessory spleen, and they're all to do with the embryological derivatives when the spleen is formed. So as we know, the spleen does not form as a whole organ. They form from small splenules that are usually found around these areas, around the ligaments, around the pancreas. Then they migrate together to form a consolidated organ. So one of the embryological, when these areas don't fuse, you have splenic accessory spleen in those locations that I've written down there. Most commonly in the hilum of the spleen, but they can also be found at the pancreas, the greater omentum, the gastrosplenic splenocolic ligaments, and they can go down right to the pelvis near the left ovary and the left testis. So it's an important component to look for, especially when you do a splenectomy in patients with an underlying hematological cause of splenomegaly. Histology is important as well, because most of our postoperative management is also centered around this and the complications with removing a spleen. So as we know that the spleen is made up of a white and red pulp. The red pulp forms 90% of the spleen, and usually where phagocytosis occurs. So that's the red pulp. So in the periarticular regions, you have the white pulp, which is responsible for a lot of immunological functions. They don't only form reservoirs for platelets, but also other clotting factors. And also in fetus, they help. It's the site where blood production is made. And also they're also responsible for repairs and destructions of red blood cells. They term this as pitting and culling. I think pitting just refers to removal of degenerative blood cells, and culling is the removal of this hard structural bodies called Haynes bodies, Howell-Joel bodies, and these are usually seen in the blood film post-splenectomy when this function has been removed. But most importantly, the functions that help immunologically is the opsonization and the production of antibodies, especially towards encapsulated organisms such as Hib, pneumococcal, meningococcal, and so forth. So splenic abscesses are a very uncommon, cause of pathology, rather. The incidence is still not known yet because not a lot of cases have been recorded. Some literature puts it at about an incidence of 0.5 to 0.7, and usually occurs in a bimodal distribution. Those who are in middle age category, 30 to 40 years old, and those who are about at the 6th decade of life. The importance of recognizing splenic abscesses because it carries a high mortality up to 47% and 100% on patients who are not treated, especially with antibiotics. And they found that if you do recognize and you do treat patients earlier on, you lower this mortality rates by 10%. So it's an important aspect to know about and identifying patients with splenic abscesses. And since the incidence are very low, there was a paper that was produced by Datey et al. In about 2015 that said that the papers that have been seen internationally have only recorded about 600 cases worldwide. So the incidence are very low. So most of the management practices have been derived from institutional experiences rather than randomized controlled studies. So I was surprised to find that there are other risk factors associated with splenic abscesses. And one of the common things that they found was that high association of bacterial endocarditis or vegetations in patients with bacterial endocarditis. About to 10% of patients who are diagnosed with splenic abscess have an underlying endocarditis. And then you have other immunocompromisable states such as, or immunosuppressive states such as diabetes. They have a high association in patients who have AIDS and HIV, but also patients who have malignancies, and it's also seen in patients who have been treated conservatively for splenic trauma. The most common organisms that they found was Staph aureus, E. coli, Chlamydia, Streptococcus, and the rest listed there. But it varies by geographical location. Like in Taiwan, the highest microbial causes was Chlamydia as compared to Italy, which they had in the 15-year study, the highest rate of microbial complications was from tuberculosis. So it's institutional dependent, but those are the top 4 organisms that are usually expected with splenic abscesses. The clinical features usually you see this classical triad of a left upper quadrant pain, you have fever, and you have splenomegaly. But other patients don't present with a splenomegaly. They have very non-specific signs. They can just present with a fever, left upper quadrant pain with high white cells, or some underlying pleuritic chest pain or left shoulder tip pain, or a incidental finding of a reactive pleural effusion on a chest X-ray. But for patients that for one of the patients that we had seen in CWM 3 weeks back, he had this classical triad of left hypochondrial pain, fever, and an enlarged spleen. So knowing the risk factors leads you to the pathophysio of how these risk factors actually link up to form splenic abscesses. The most common pathophysio is seen in infective endocarditis is through a septic embolization. So you have a septic emboli from the vegetation of infective endocarditis. This lodges into the bloodstream and then goes and lodges in the parenchyma of the spleen. And apart from infective endocarditis, this is the most common pathophysio for patients who have central line sepsis. Those have a fungal infection, and also patients who are immunocompromised, especially those who use long central lines for chemotherapy in our patients with underlying malignancies. And apart from that, those patients with HIV and AIDS. The other pathophysio of how trauma leads to a splenic abscess is usually we say that when you have a splenic trauma, you do conservative management. You have a residual hematoma that which becomes infected, and this infected. So this becomes a nidus for other bacterial infections to set in. And in vascular hematological malignancies, you have infarcts. And these are usually seen with patients of underlying vasculitis or they have a sickle cell disease. Knowing the surrounding structures also leads you to understand the pathophysio of how contagious spread comes from the pancreas, comes from the stomach, and also comes from the colon in terms of having gastric and colonic perforations, as well as having splenic abscess as a secondary result of necrotizing pancreatitis. And then you have those
So Leslie, can you still hear Anna?
No, we can't.
No, can't hear.
Anna, your microphone is off. Hello, Anna. Must have been her internet connection. I think she's dropped out.
Okay.
Should be back soon.
So Leslie, what percentage of population that have accessory spleen?
Sorry, I'm not. I don't know.
Okay, anyone? About 10%, eh? So 10% have splenomegaly. So whenever you're removing the spleen, you should make an effort to look for splenomegaly, because that will be the reason for ongoing concerns with hematological problems. So she's back. Okay. Anna, we can't hear you.
Yes. I am back. So sorry about that.
Must have been one of the cats there.
Okay, so where were we? We're going at the radiological investigations that you use. You can use ultrasound scan, but the gold standard for diagnosis is CT scan, where you expect a non-enhancing lesion or low-density lesions. And it's not just diagnostic, it offers a therapeutic advantage because they can see the surrounding structures, the size of the splenic abscess, and then plan your treatment modalities after this. This is a CT scan of our patient, a 65-year-old gentleman who came in with a splenic abscess. So you can see there it's multilobular. I have one lobe there, another one down below. And it's usually a huge cavity. Yes. The hospital units were consistent with that of the splenic abscesses. And as you can see, it's non-enhancing. This is a contrast run. So what is it?
Anna, go back to that CT. Is there two abscess or just one big abscess cavity?
It had when we opened it up after we dissected, there was one big abscess on the top, another one posteriorly.
They're both communicating.
Yeah, maybe the opening, but it looks like could be one. But
Okay.
when we dissected, there were two shallow cavities. So
Yeah. Keep going.
sure. So as I said, the data that recommends treatment is mostly from institutional studies, and this most of the literature that I read, there's no consensus on what to do. It's usually patient dependent, institutional dependent, and the other patient factors that you factor in. But usually the first line of treatment is antibiotics. This study in particular in Jankong University in South Korea, the most common empirical treatment they put them on is Kaftria Flagyl, IV Flagyl. And then they go down the pathway of percutaneous drainage or splenectomy, depending on the patient status. This is another case report from Italy that studied patients around more than a 10-year period, and they accumulated about 16 patients, and they share the same sentiment that I had mentioned before. So they had stated that percutaneous drainage is usually reserved for patients who have a unilocular collection and patients who are more rebound. So you have patients who are not anesthetically cleared, but you can do this temporizing measure of draining source of infection prior to clearing them for OT or prior to stabilizing them. It's usually the greatest advantage it offers is that it allows for the preservation of the spleen, but it's usually not advised for subcutaneous collections or those collections that have a lot of debris, since you can't remove it through it's usually difficult to remove through a percutaneous drain. Most of the authors in this literature review had given a caution that you proceed with percutaneous drainage under this treatment pathway, provided that your coagulopathy profiles are normal. And they also said like it's quite difficult to see hemorrhagic lesions differentiate hemorrhagic lesions on a CT scan. So when you do offer them percutaneous drainage, you place them at an inherent risk of developing catastrophic bleeding when those lesions are not an abscess related. And they usually advise that you do percutaneous drainage in facilities that have an operating theater readily available, or where you can do embolization readily. It's not a treatment modality that I advise for when those two treatment options are not available, the OT and your embolizing suites. But despite that, even in centers where they have interventional radiologists, most of them are reluctant to go down this treatment pathway because of the inherent risk of having uncontrollable bleeding, since the spleen is a vascular organ. And on top of that, quite difficult to negotiate the colon and the other structures around it and the diaphragm. So they usually advise this in centers where there's specialized interventional radiologists readily available. So your contraindications for percutaneous drainage would be, as what we've mentioned, multiloculated abscesses, those who have multiple small abscesses that are not enabled to drainage, those who have, you can't see clearly the route of drainage, And on top of that, if you have like a contagious spread, like from the colon or pancreas or stomach, that you might want to do a laparotomy for. And in certain cases, ruptured abscesses. This was a paper out of Taiwan that also shared a similar sentiment, that in their center, the failure rate of percutaneous drainage was up to 50%. So they usually, most of the usage was actually directed towards patients who were critically ill, who had several comorbidities, and they used it as a bridging treatment modality for patients who are not cleared yet to have surgery. It's something that you can pick and go read up. So apart from antibiotics, apart from your percutaneous drainage, the other option is to offer them splenectomy. Currently, worldwide, most have moved towards laparoscopic splenectomy as opposed to open, because of the advantages that a laparoscopic setup offers. You have decreased it's minimally invasive. You have decreased post-op pain, decreased length of stay at hospital, and cosmetically it's more pleasing because of more smaller scars that you have. But splenectomies are usually offered to patients who have multifocal abscess collections, those who have multiple septations, and those who have had failure to medical treatments or failure to percutaneous drainage. And I will be discussing on open splenectomy because I've only seen one laparoscopic splenectomy done in a pediatric patient. So the position is key. Usually in splenectomy, we roll something under the left flank to bring that area a bit closer to the surgeon. The incision is dependent on the situation that you're in. Can be a left costal or midline. In trauma settings, you'd move towards a midline approach because you want to see the four quadrants of the abdomen. And also in patients who have a hematological underlying cause for splenomegaly, you actually look for these accessory spleens at the sites that we've mentioned. So if you're the main surgeon, you stand on the right side of the patient, and your first assistant or second assistant stand on the left side of the patient. And once you enter the abdomen, adequate exposure is key, where you expose the left upper quadrant. And if you're in a setting where you have these retractors, you can retract the colon downwards. But the goal for this splenectomy is to mobilize the spleen medially, and you dissect down to the pedicle of the splenic artery and vein, which is then controlled and divided, and I explain to you in the next few slides. So as we mentioned, one of the ligament attachments that come from the stomach to the spleen carries those short gastric vessels. They usually say you try and open up from an area that's avascular, and you try and get control of your short gastric vessels, but be very mindful of your stomach. As you approach the upper surface of the stomach, the vessels here get very short, so the high risk of bleeding. And apart from bleeding, you have a higher risk of causing an iatrogenic injury to the stomach. So they say when you're in doubt, where you might have been too close to the stomach, you can place neuromuscular sutures there and invert the area. And apart from that, in cases where you have massive spleens, they usually say that you move on to trying to find your splenic artery. And this can be located near to your smaller, ligated after your short gastric ligation of your vessels. The splenic artery for once can be found either by going towards the gastrohepatic ligaments and the lesser curvature of the stomach, or you can enter the lesser sac. And as we mentioned, the artery is usually on top of the pancreas, and you can take control of the splenic vessels after entering the lesser sac, and finding it on top of the pancreas. Once you've identified this, then you can move on to your splenic dissections and your medial mobilization of the spleen. So your splenic mobilizations, we usually start from the inferior poles, your splenocolic attachments, then you work your way above. When you're doing so, you have to be mindful of your colon that is in close proximity. And deeper to the colon, you have the adrenal gland. So as you take course, when you try and separate the splenic attachments, you have the left gastroepiploic artery that you'll encounter, and this is controlled, ligated and sutured, or you use a ligation and you can take control of these vessels here. So your left hand is key here because you retract the spleen medially and you work around the attachments in trying to divide those attachments, splenoregal and splenophrenic. In the setting of trauma, usually this dissection is done for you, and the hematoma usually pushes this spleen anteriorly, so you don't have to do much of these dissections around the ligaments, the lateral ligaments. You just take control of the hilum after you do your four quadrant packing and after you have done your ligamental release and you medialize the spleen, you look at your splenic vessels. They usually say you tie the vessels individually, your arteries and your veins, using this 3-clamp method. So you have 2 clamps proximally and 1 clamp distally towards the spleen. The common areas where you find bleeding after the spleen has been removed, and you try and make sure in cases where there are hematological underlying malignancy, you don't leave any of this tissue behind. But apart from that, the areas that you check for hemostasis is usually at the diaphragmatic surface, the greater curvature of the stomach, or the hilum. And if you find that the diaphragmatic surface is bleeding, it's where you can actually put a pack and let it sit for a while before you come back and check. So this is 2 cases that this is the first case that we've did about 3 weeks back. This gentleman is a 65-year-old Fijian male who has been coming in since February on 2 separate admissions for fever, left upper quadrant pain, and has just been unwell. Blood cultures grew E. coli, and then on further imaging, we found that he had a splenic abscess. So he's had 3 admissions, and upon discussions, we've decided to proceed with a splenectomy, because his treatments were not settling with long courses of antibiotics. The other splenectomy that we did was for this 31-year-old boy from Nanronga, who's referred for left upper quadrant pain and on and off fever. So it was actually taken in because of a ruptured splenic abscess. We had about 1.5 liters of peritoneal fluid abscess of a collection. So we had taken, this picture shows that he had multiple areas of small infarcts and small areas of where he had the collections at. This is the medial surface of the hilum, the hilo of the spleen. The complications are usually related to your anatomical relations. So you can have a pancreatic fistula if you inadvertently clip the pancreatic tail. You can have portal vein thrombosis. You can have secondary bleeding from that area, and colonic and gastric preparations if you do diathermizing burns, or when you do cut along those areas. And apart from that, the collections in the subdiaphragmatic space is a common, it's one of the things that you look out for, apart from the atelectasis and the reactive pleural effusion that you see. But the late complications are usually infection related. Within 2 weeks of 7 to 14 days of post-splenectomy, you have increase of platelet counts because they don't get destroyed. So you have thrombocytosis. And apart from that, you have your more amenable to pneumococcal viral infections and your overwhelming post-splenectomy infections later on. So your follow-ups include your vaccines, your antibiotic prophylaxis, and anti-malarial, especially if you're going to endemic areas that have malaria. They would advise you to take this anti-malaria tablets before traveling. The vaccine, OPSI is also known as overwhelming post-splenectomy infection. It occurs about 2% of patients within 2 years of post-splenectomy. And it's usually associated with encapsulated organisms like the ones listed there. The mortality rates are quite high, usually about 50 to 90%. And the symptoms vary for your prodromal phase of just having fever, headache, non-specific GI symptoms, to a fulminant infection where you have multiple organ dysfunction. So your renal shutdown, you have cardiac arrhythmias, and you have other organ involvement. So they usually recommend that to prevent this overwhelming post-splenectomy infection, that you vaccinate patients usually at day 14. And why day 14? Because studies have shown that the body has the highest antibody titers for the most common serotypes at day 14. This is a study that was done about 1998 and was the basis of why we do immunization at day 14. And they found that the antibodies were highest when at the day 14, after day 14 as compared to day 1 and day 7 post-vaccination. But what happens to patients where you can't ensure that they return for immunization, for vaccinations? Well, you can still vaccinate them, especially upon discharge, so that they get some form of coverage. But as we said, the maximum amount of immunity imposed is after day 14. But if you're unsure of clinical review, you would still vaccinate them at discharge, regardless of whether they've reached the day 14 post-splenectomy. And that's an article that we can go look at after. So different vaccination differs among different countries, but this is usually something that this guidelines is from America, Britain, and Canada. So it's usually a 5-year vaccinations for your pneumococcal and meningococcal with boosters intervene, and then you have your annual flu vaccine. They recommend because of risk of secondary bacterial infections. So they have different types of vaccines there. The 23-valent one doesn't offer better immunological reactions as compared to the 13 one. So they usually, most countries give them together in a combination. The MENA ACWY, which has a longer serotypes, more serotypes for pneumococcal, but less immunogenic responses as compared to the 13-valent one, which has less serotype coverage, but more immunological responses on the patients. Antibiotic prophylaxis, is this recommended? Well, there's very little evidence in literature to suggest daily antibiotic prophylaxis in adults. One of the reasons that they don't go down the treatment approach is because of lack of compliance and the high risk of having resistant pneumococcal strains. But the guidelines are there for daily prophylactic antibiotic in the form of benzyl penicillin for children who are under the age of 5 years. But worldwide, there's a lack of consensus as to how long this treatment should be continued or when this treatment should be stopped. But this British guideline had recommended that in Britain or in the European countries, they recommend prophylaxis after the age of 16 and for high-risk patients. Those high-risk patients are those who have immunosuppression. Those are above the age of 50, less than 16, or they have an underlying hematological malignancy for which they had undergone a splenectomy. Or they've had, because they test the serology responses after you take these vaccines. If you don't have an adequate response, they recommend you to be on this antibiotic prophylaxis. But as I said, the duration and all this is still not very clear in literature. I think patient education is something that we really need to work on here in Fiji. Obviously, they put on medical alert bracelets, so they tell the medical personnel or if someone finds them in that state of being comatose that they have had a splenectomy. And it's very importantly so, because vaccination does not mean that you have full immunity. For instance, the pneumococcal vaccine only covers about 70% of, only confers about 70% of immunity. And in a setting of OPSI, septic shock, they usually require you to get treated as soon as possible because studies have shown that you reduce the mortality and the morbidity associated with OPSI if you get treated early. And it's something that we need to tell our patients is how to recognize OPSI or this OPSI symptoms, like illnesses that you see, the fever and the other prodromal symptoms, and what they should do when they do have this slight fever. They should first take their first antibiotics, and then they present to a medical facility. And most papers recommend augmentin and levofloxacin as a supply that patients should have at home. Is there any questions? That was my first adult splenectomy with Dr. Ndalasau, and he coded he needed a beer after that. Do you have any questions?
Okay, we'll start off with a case. Can questions in regards to how these 2 cases were managed?
Okay. So the first case that we had was a referral from the medical team.
Yeah. So this 65-year-old
Yes,
has
he
had
had,
recurrent symptoms for a few months prior to surgery.
yes, with non-specific symptoms. He was admitted under medical for what they thought was some renal infection. Was treated conservatively on antibiotics, went home, he was in February, went home in February, represented again at end of February, March, with non-improving symptoms. He still had the pain, still had the fever, and more so on the March, April admission, he had the left upper quadrant pain.
So was he
So
diagnosed twice prior to the
yes,
recent diagnosis?
he had a scan that was done that suggested a splenic cyst, but was not referred. And by the time he had come in to do the CT imaging, we had found that he had a splenic abscess. So what we were thinking, maybe that cyst was actually a splenic abscess that was just getting bigger over the course of 2 months.
Okay, because that's one of the reasons why patients can develop splenic abscess, is having an underlying splenic cyst.
Yes. And apart from that, we also had E. coli sepsis. E. coli, he initially had E. coli virosepsis.
Yeah.
And then on this admission, he had E. coli septicemia in blood. But we done an echo for him that was clear, didn't show any vegetations.
Okay.
And the aspirate that we took from this OT was also showed E. coli. So we treated him as per sensitivity for E. coli. So he is on Caftri for at least 14 days or so or
Okay.
more.
And why didn't you drain it first? Why did you proceed to doing a splenectomy as a first line of surgical management?
Because we were thinking, we were not convinced that it was a unifocal lesion. And because the fact that he's been having recurrent symptoms, he was not, I mean, he's not clinically not well. We thought that removing the foci of infection would do him much better. And this gentleman, it was not from Suva region, it was somewhere from Namosi. So
Yeah.
getting him back for treatment and getting him back for clinic was another issue. Like we couldn't guarantee that he would come back for treatment and those reviews. So we thought the long duration of symptoms, he's not getting better on treatment of antibiotic. And upon discussions with our overseas team, we thought to go ahead with a splenectomy. And we're not convinced of that imaging that it was unilocular.
It looks
That's
like
very-
the CT, that just one big collection of abscess. So the answering for the exams. Yes, this could be amenable for drainage, but we don't have the expertise for that, as you had said in your presentation. So I would not attempt doing a percutaneous drainage. Hence, I would proceed and do a splenectomy.
Sure.
So I agree with your answer. How you say it. You have to convince me that you have done the right thing.
Sure.
I agree that you've done the right thing, but you haven't convinced me enough. Because in my setting, I probably would have drained that percutaneously first.
Yes, yes. So radiological intervention would be the other issue. Non-experienced centers, percutaneous drainage would be the first line of surgical management, surgical drainage, and that's applicable to our settings.
Okay. And the second case, I mean, obviously that needs a laparotomy.
Yes, so this 31-year-old gentleman was referred from Singapore for non-specific left upper quadrant pain and an incidental finding on, he was admitted for a week in Singapore, then referred over because they had found an abscess with a cyst on ultrasound scan. But during his admission here, he developed peritonitis. So
how many days after admission? He
came in 2 days down from admission. They had done a CT scan on arrival, and then the day after, it showed what seemed like it was going on the night morning. So it showed like a bowel obstruction, and with the peritonitis, we were not too sure where the foci was, but the CT scan was not too convincing. We saw patches of hypodense lesion. So we suspected that it could be a splenic abscess, but we decided to proceed with a laparotomy because he had underlying peritonism, and CT scan suggested a bowel obstruction. That's why we proceeded with an open splenectomy, open laparotomy, then which ended up as a splenectomy for him.
Okay. Go back to your CT. Describe the findings on the CT.
So this is looks like a large enlarged spleen. It spans from, this is the 12th, 11th, 10th, 9th, spans a whole 9th to 10th region. There's an area of, this is a contrast run, so a hypodense lesion that you can see there on top, and also at the bottom towards the spleen. It's not taking up contrast as the other surrounding structures around it. And it seems very diffuse in nature.
Diffuse or well encapsulated?
Yeah, like
Well demarcated.
encapsulated.
Rest of the
Yes,
splenic tissue, eh?
yes. well
And I
done.
think those two are communicating if you look at the sagittal view.
Yeah, this one. Yeah.
And often it has a hypoattenuation, or as you had described, hypodense, well attenuated or well circumscribed. And on the CT, there's no calcification, which is the pertinent negatives that you should mention. Hence, with chronic cysts, often would have calcification ring around it.
Okay.
So this is an acute abscess rather than a chronic abscess.
Okay.
Okay. So summarize the principles of your splenectomy. You've described the steps in detail. Give me the principles.
So incision, depending on your underlying setting, you do
Right, so
adequate exposure,
Adequate incision.
adequate excision, adequate exposure. You medialize the spleen, take control of your vessels, and then you would ligate and remove your attachments, and then you control your splenic arteries and veins, and then you would
Principles should only be 5. So one is adequate incision.
adequate exposure,
Of what?
exposure of visualizing the spleen.
You will see the spleen. You put your hand onto the spleen, you will feel the spleen, or if your incision is big enough, you should be able to see the spleen. But what's the next crucial step?
Medializing the spleen, or
What do
getting
what do you
control of
mean
your
by that?
gas. So you get a control of your gastric ligaments, and then you remove the attachments from around it.
So you need to control the short gastric.
Yeah, short gastric first, then your
Yeah.
ligaments.
And then what's the third principle? You mentioned it in your talk.
Get splenic vessel control.
You do that last. Once.
You medialize it, you free up the ligaments.
Okay. So division of the ligaments, which include phrenosplenic,
Phrenosplenic, colonosplenic, and
colosplenic,
linorenal.
linorenal. That's the third crucial step.
Yep.
And then fourth step.
Control your splenic vessels, your arteries and veins. You clamp them individually.
Okay. And the last one.
Closure, removal and closure. And
Okay. So if you contextualize the thinking into principles, you'll realize whatever you've described, you can talk about it in 2 minutes.
Sure.
Adequate incision, control of the short gastric, mobilizing of the 3 attachments, and then you come back to the splenic artery and the splenic vein, which you've described as taking it individually or whether you enmesh close, and we'll come back to talk about it.
Okay.
And then making sure that you achieve good hemostasis before you close. Yeah. So
Sure.
let's talk about principles, eh? Okay.
Sure.
What else? If this was an ultrasound scan, same patient looking at the CT, if he had done an ultrasound scan, what would you expect to see? Because for this patient, I would have done an ultrasound scan first before doing a CT.
Hypercoic lesions, you can comment on globularity.
Yeah. And
multiple
again,
coagulation.
well-defined splenic collection or hypoechoic collection within the splenic tissue. Eh?
Yeah.
It's often the difficulty differentiating between abscess versus a cyst, hence why you would do further imaging with CT or MRI.
Sure.
Okay. Choice of antibiotics?
It's institutional dependent, and it depends on clinical
How
status.
for this patient?
This one was he was put on Cloxa and Caftry
Yep.
for the 65-year-old gentleman.
Yep.
Cloxa initially before they got the cultures for E. coli, and E. coli was sensitive to Caftry, so they continued with Caftry.
And that was based on the culture of the abscess.
It was based initially on the blood culture,
Yeah.
which showed E. coli sepsis in blood.
What about the
And
abscess?
that was also E. coli, so they
Okay.
continued on capture.
How many days?
We had seen him, he had completed more than, by the time we came, he had completed more than 14 days from culture negative.
Okay. So again, you should mention something about, given that the echocardiogram was negative, or
Yes.
there's no evidence that the debate between 1 week versus 2 weeks, no one really knows the answer. Okay. Now, the rest of you guys, any other questions on those two cases?
No,
No? Okay.
no question. No.
I have a,
Yep.
sorry, no, I was just reading, like, because laparoscopically they have a lot of emphasis, like, does it carry weight on what you clip first? Like the
Question.
artery or the vein? Because
Good question. The answer is no.
no.
What you're trying to avoid, which you didn't mention in your complications, is the fistula forming between the artery and the vein. I've never seen it.
That's why you tie them individually, separately.
That's right. That's the thinking behind it.
All right.
I just do endoclips, or I do use a ligature and just clamp through the vessels. Or once I've isolated the hilum, I don't isolate the vessels. And I'm saying that I've never seen a fistula. Maybe the adult practice would be different, that you take the artery first when you do it laparoscopically. I have seen the evidence. It's not very strong, but people do, or people are aware of the potential fistula formation between the artery and the vein.
Artery and the vein. Okay.
But when I do it laparoscopically, I still follow the same principles.
Okay.
Take the short gastric first, then I divide the other three attachments, and then I come back onto the hilum. And don't forget in the 10% that you have to look for the splenonuclei. If you're doing an elective, even in an urgent hematological splenectomy, yeah?
Right.
Still have to look for the splenonuclei. Now go back to your literature. So to summarize all that, okay, so you've talked about the anatomy. Yep, go down. So you've talked about the anatomy of the spleen. You've talked about the various blood supply. You've talked about the functions. You've talked about splenic abscess. Summarize all that.
So, the splenic abscesses, the important thing to know is to have an underlying risk factor associated with it, because your management is affected by screening for immunocompromised states, getting an echo done.
Okay.
And your treatment modalities depend on a lot of things: patient factors, institutional factors, and surgeon factors. But in our setting, where we don't have experienced interventional radiologist, percutaneous drainage would not be the treatment pathway that would go with. An open splenectomy would be offered, but then on the context of close monitoring and updating patients on the complications and the reasons for vaccinations.
Okay. So splenic abscess, it's rare. Has anyone else seen a splenic abscess? The last one I saw was when I was a junior registrar in Fiji. So it's very rare. So you should start off with something. If something is very rare, that means the incidence would be less than 1%. Yep.
Yes.
So start off with incidence, or in a surgeon's gowns, physician may make some progress, or versus summarizing what you've said is, one, this is very rare. So the incidence would be less than 1%. And obviously you can't do randomized control studies. So you'll be relying on case series and case reports on how this should be managed.
Yes.
Yes, you said it's hematological spread, but always think, is there an underlying splenic cyst that have led to the abscess in the first place?
Sure.
And then your management, once you've confirmed the diagnosis, either with an ultrasound plus or minus further imaging with CT or MRI, and then the drainage versus a splenectomy. So your indications for drainage would be if it's visible, if it's available, and if you have to, as we would do here, we would again check the coagulation first before we would intervene. Versus those ones that will require a splenectomy, as you had described, complicated ones, those ones that have ruptured, large one. But obviously, all these patients should require antibiotics, which would include the small abscesses or multiple abscesses. Those ones should just be given antibiotics only that are not amenable for drainage. So you subclassify the abscess into one big one, amenable for drainage, versus one or two that requires a splenectomy, versus the small ones that should just be given antibiotics only. To summarize all that,
Yes.
Okay. Questions from the rest of the group? Questions, Anna?
Mm. Mhm. Mhm.
I see you guys using book, Walter.
Dr. Toko, sorry.
Yep. Yes, sir.
Just wanted to confirm again. So you're saying that we have to control the short gastrics first before we
Easier.
midline the spleen?
It's easier
Okay.
because you want to make sure that you're dividing the short gastric to separate the stomach first. You don't want to perforate the stomach.
Okay.
In a trauma setting, like they usually have all these ligaments out. The steps
Yep.
would be
You pack in trauma. You pack first.
pack first. Yes.
Pack first, and then you go and see where you can approach. But elective or something like this for liver abscess, go for the short gastric because those are the vessels that will tear.
All right.
Gastric first. Okay.
So when I do it laparoscopically, again the same thing. I go for the short gastric first. So that should be the second, I suppose, this, for me, the second principle of doing a splenectomy.
Gastric. Okay.
And it's a small window that you go through with your diathermy, or with, if you decide to tie, or if you use the ligature, it's a small window. So stick close to the spleen rather than the stomach.
And when we're like, do you routinely leave drains, like in cases where you are worried about going near the pancreas?
Good question.
Because like most
Salasi,
us here, we do.
Salasi, would you leave a drain post splenectomy?
So I would leave a drain to, if I would be worried about, for this case, I would already wash out all the pus and check for hemostasis before I close. But then there are other organs around that I would be worried about, such as
Salasi,
yeah.
Exams. Would you leave a drain post splenectomy?
So no need to leave a drain.
Excellent. Because as you had said, that you'll achieve good hemostasis, you'll make sure that you've done good peritoneal lavage, and you would not leave a drain. That's the exam answer. What do you do in practice? You can decide once you go back to Tonga. No one cares.
Right.
Yeah, because evidence have demonstrated that the drain makes no difference to the outcome. You should not be cutting into the pancreatic tail when you're doing a safe splenectomy. It's the ones that are so edematous, so inflamed at the hilum that you are not certain whether you have included the tail of the pancreas or not. Those are the ones that you might need to consider a drain. But in the exams, no, I will do a safe splenectomy. I will identify the tail of the pancreas to make sure that it's preserved. Having achieved good hemostasis and having done a proper peritoneal lavage, I will close the abdomen. Yep. Okay.
Yes.
In the exam, don't allow the examiners an opportunity to tear you down with drain versus no drain. Okay. Next question, Anna.
No drain.
So hopefully you guys didn't leave the drains into these two patients.
We did for the 65-year-old male because it was very difficult. It was very had a lot of adhesions, inflammatory adhesions. So the architecture was quite distorted. So we're not too sure. We'd worked very closely to the pancreatic tail. So we had put in a drain, and we tested amylase every second day.
Oh, you boys are too soft. Okay. Tell Naita Sirifala to.
Boss, have you seen any pancreatic fistula? Any?
Oh, because I identify the pancreas. So that's the relevance of the anatomy being discussed, is that because if you don't look for it, you will traumatize it. Even in trauma, because everyone is, I suppose, it's that anxiety, it's the panic feeling that you're not controlling bleeding. But if you pack, allow yourself good exposure, you will identify the vessels and identify the pancreatic tail rather than just putting clamps blindly.
True.
So no, I haven't seen a fistula of the pancreatic tail because I always identified.
Sorry, Vinay, like in a case that you, sorry, I just wanted to ask, in a case where you might have had caused an iatrogenic injury, do you use like a non-absorbable to sew over the area where you think there's a pancreatic injury, like a non-absorbable 6 or 7, or what type of suture would you use?
For splenography, we don't do splenography. We treat everyone conservatively. Even if you come in with a grade 4 splenic injury, we would still treat you non-operatively.
Non-operative. And when would you embolize? Like which?
You might consider for grade 5 that have ongoing issues with ongoing blood loss.
Okay.
So the non-responders, they are on blood transfusion, they're in ICU, and they're still hypotensive, they still tachycardic, you might need to embolize those.
Okay.
And saying that, I've been here now for 10 years, haven't had to embolize any.
Okay.
Even for grade 5, I just sit tight. The bleeding will stop.
And sorry, Vinay, have you experienced having like a pancreatic tail injuries? Do you, like, if you think you've injured, do you sew over with a non-absorbable suture, or how do you manage those ones, like intraoperatively, where you close the duct?
So the pancreas, if you've seen the pancreas, is actually very soft. And if you put a running stitch, if you put a running stitch, it will just cut through. So grab a piece of momentum and attach it onto the tail.
Okay.
The idea behind is you want to close off the pancreatic duct. That's where it will leak from, rather than the actual pancreatic acina cells. It's the duct that you want to control. So if you put an omental patch onto the duct, hopefully that will seal it off.
Okay. And it doesn't matter the type of sutures, like you don't have to use a 6-0 Prolene or a PDS.
That's what I tend to use, PDS or Vicryls, my sutures that I tend to use.
Okay.
I wouldn't use the non-absorbable sutures though.
Non-absorbable.
No, wouldn't use non-absorbable, no.
So in that case, was your liver drain when you've noted a injury?
That's right.
Yeah.
That's right. So that's a complication.
Yes.
You want to minimize the side effects or the complications of your pancreatic injury, hence why the drain. But if you think about it, even in children with pancreatic injury that involves the body or the tail of the pancreas, we would still manage it non-operatively. So you don't really need to drain anything.
True.
The patient will develop a pancreatic fluid collections, which will become a pseudocyst. So what? Then you can drain that after. But it's always the instinct that we have to liver drain.
Okay.
Noted, boss.
How you answer in the exams? Okay, any other questions? I would suggest that you people write these 2 cases and submit it to the Pacific Health Dialogue, because they are rare. So you should write them.
Sure.
There's 2 case reports of splenic abscess.
Yeah, we'll do, Vinay.
Okay. What's the time? 1 hour.
Because I think Sanjit has a question there.
Yep.
He's posted in the chat. He says the choice of incision.
Okay, Sanjit, answer your own question. What incision will you do?
Comfortable.
Good. So when you're starting off doing laparotomies, it's probably best to do a midline incision. Yes, you ideally a midline incision. So in the setting of pancreatic, splenic abscess like this, I would do a midline incision. Trauma, I would do a midline incision. In children, we would do a transverse incision. I wouldn't do a subcostal in the acute presentations or acute surgery. So exam answers is a midline laparotomy.
Midline.
Because that's what you guys do quite a lot. Eh? So that's what you should be comfortable in doing, whether you're starting off or second or final year of training, you should be able to do a midline laparotomy. Okay, questions? Oh, Anna, by the way, the splenonuclei happens in about 10% of the population. Eh?
So there can be normal variants or like
No, 10% of the population.
10%. Oh, okay.
have a
Occur in
spleen.
10% have
Yeah.
spleen. Like, okay.
So when you see, when you're removing the spleen, you think about, maybe you should check. Eh? So for children, in terms of the post-operative, post-splenectomy, we use the STASIP guidelines, which is 2 years of being on oral penicillin.
Oh, penicillin.
And then after that, they should have penicillin with them with the advice of coming into the hospital as soon as they feel unwell. Because I saw that was one of the questions that you raised as to the duration. It's the first 2 years, which is the critical. Hence why in kids with blood disorders that requires a splenectomy, I tend to push it as, till they turn 14 or 15 or even older before I remove the spleen. Because the younger they are, the higher the mortality from OPSI. Yeah?
So you put them for 2 years duration,
Yeah, oral penicillin for 2 years.
or penicillin for 2 years. And if they, and it's also life, you mentioned also up till 14 or 15 years of age, or
14 or 15 is when they push. Like if I'm seeing a 10-year-old patient with some sort of hematological disorder that requires a splenectomy, I'll try and push it as late as I can.
so
Because
cutoff age would be that 14 or 16. That's what you're saying. Okay, okay, all right.
before they become an adult.
Okay, sure.
I've had to do a couple young around the age of 5 years just because of the increased use of steroids, and they're requiring blood transfusion almost every month. So there are a couple that you might have to do for hematological conditions. You do them early, but you keep reminding them about the risk of OPSI, because it's high in children as compared to adults.
In children. Yeah.
That's it from me. If there's no other questions, we should end it then.
Thank you.
Good
presentation. Anna, you should write this up.
Sure, then, thank you.
Okay, I'll leave it to whoever's coordinating, whoever's coordinating to end the meeting.
Yeah, sure, was ending it now.
Okay.